right. Hi, everyone. Thanks again for coming out tonight. We have another great lecture for you. Tonight, we have Dr. Michelle Gutman here to speak to us about augmentative and alternative communication. Dr. Gutman is a clinical professor at Purdue University's Department of Speech, Language, and Hearing Sciences, where she teaches the graduate AAC course and has taught both counseling and communication disorders and motor speech disorders. After completing her doctoral studies and prior to coming to Purdue, she served as a clinical assistant professor and the speech language pathologist for the ALS clinic at Vanderbilt University Medical Center. Prior to returning to doctoral studies, Michelle worked clinically for approximately a decade with both children and adults who needed AAC. She is part of the team that edited Tele-AAC, Augmentative and Alternative Communication through Telepractice, and the recently released textbook, Fundamentals of AAC, a case-based approach to enhancing communication, and is passionate about working with adults with acquired and or neurodegenerative communication disorders who need AAC. Michelle served as the professional development manager for ASHA's SIG-12 AAC from 2017 to 2023. She is active in both research and clinical endeavors related to the application and implementation of AAC for adults with neurogenic communication disorders. Her interests include telepractice, interprofessional education, clinical education in speech-language pathology, implementation science, and health literacy. Michelle has published and presented nationally and internationally. With that, I'll turn things over to you, Dr. Gutman, and thank you for coming out.
Thank you. All right. Hello, everybody. Welcome. I don't know if you're NCAA fans or women's basketball fans, but I will say I'm here at Purdue. We made it to the Final Four and made it to the championship game, but unfortunately didn't win in the championship game. But anyway, it was a very big day for Indiana yesterday. Plus the eclipse, we were not right here, but further down in Indianapolis in the path of totality. So this is all very exciting. I'm thrilled to be here tonight. I'm excited to see you and meet you. I see that you're all muted and have your mics off, etc., and your videos off. Maybe you could help me out, because what I'd like to do is open by asking if anybody has any specific questions, or if you wanted to review questions in the praxis, in the therapy ed practice exams. And otherwise, I will go through my slide deck, which provides a review. But if you have specific questions, I'd be happy to address them now. So if you want to put anything in the chat, please feel free. Okay, not really seeing too much in the chat. Okay, so let's get started with a review, and then I would just like to clarify, please ask questions as we go along, and that would be helpful. So I'm gonna share my screen. Not that one, hold on. Well, okay, can everybody see that?
Yes.
Okay, are you seeing my whole screen, or just I think it's showing on the wrong screen on my other monitor here.
We're able to see your presentation.
Okay, so it's taking up the full monitor?
Yes. Okay,
great. Excellent. So, all right, preparing for the praxis, what you need to know. All right. Okay, so always helpful to start with a definition. Um, I would take you basically to the top one. AAC, or augmentative and alternative communication, refers to forms of communication that either supplement and or replace. So supplement is augmentative and replace is alternative, more conventional means of communication, typically referring to speech or writing. Then there's a more detailed definition that is ASHA's, and it considers things like AAC could be useful for both temporary or permanent um, impairments, activity limitations, and participation restrictions. Importantly, people who use AAC often have severe disorders of speech or language production and or comprehension, and it could be used for both spoken and written communication. So, um, really the way to think about it in the most practical sense is AAC could be for anybody who cannot meet their daily written or spoken communication needs through natural speech and or writing. Could be a candidate for AAC. There's no sort of candidacy model. There are no candidacy requirements for AAC. It's just that people can't meet their daily written or spoken communication needs through natural speech and or writing. Um, so just a little bit of terminology. It's come into more popularity now that people who need and or use AAC, regardless of the type or severity of disability, can also be referred to as people with complex communication needs, or CCNs for short. Some actually giants in the field object to that terminology. They'll never, excuse me, won't ask you a question about this on the praxis, but just FYI, because they say, for example, somebody who has a severe stutter could have complex communication needs from their stutter and all of the secondaries and ramifications of having a severe stutter. So it really isn't restricted to AAC, goes the argument. But if you see that, it often refers to people who need AAC. And then we break that down into face-to-face communication, typically refers to spoken communication, and written communication, mostly refers to text type of output, could be hard copy like a printed sheet, but it includes things like text messages, etc. Okay, so I'm going to go through the fundamentals, and I've created a mnemonic, and it's kind of long. It's more like a phrase. AAC supports for SLPs, and we're going to walk through what support that mnemonic and get into it in more detail. So A is for alternative augmentative, remembering people with either congenital or acquired chronic and progressive disorders could use AAC, could be used in language and speech development, like in young kids, or in dissolution, someone who's had a stroke, for example, or it could be for somebody who has a temporary issue, like somebody who's intubated after surgery versus a permanent issue, and often related to what you learned in motor speech, people who are dysarthric, but whose dysarthria is either too severe to be intelligible or progressive and getting worse. Access. This is a huge issue in AAC. So if you think about yourselves, you may be sitting on the couch, in bed, at your desk, whatever, and you probably have a computer or a tablet with you. And what you're doing when you're typing is called direct selection. And for many of the people with whom we work, for needing AAC, they may have what we refer to as complex bodies, meaning bodies that need support either through seating or a wheelchair or other cane, some kind of mobility aid, and they may not be able to directly access a keyboard, let's say. So in that case, we look at alternate access. So alternate access, whole sort of sub specialty in the field. Basically, we often work with OTs and PTs to do this, AAC being one of the original interprofessional functioning type of units. If your client is in a wheelchair and they maybe can't use their hands, we have to find another way for them to interact with either a tablet, an AAC device, a computer keyboard, or even a communication display. Direct selection, the abbreviation here is DS. We use direct selection whenever it's possible. It's just easier. But when direct selection is not possible or not feasible, as a sole access option, we can look at alternate access. And some people can use direct selection for a while and then they fatigue. And so then we would use alternate access. And it's very complex. And that's why we often work with OTs and PTs to determine the best site on the body for easy, consistent, reliable ways to access various options for communication. Communicative competence, this is the C in AAC, and Janice Light, and then Janice Light and David McNaughton proposed this model, and it really is a seminal model for us. And the acronym is LOSS, and the next slide details it. It's a model of communicative competence for AAC users. Oh, whoops, guess it skipped. We'll get to that after. Okay. Temporary needs for AAC, I talked about that: intubation, prescription of voice rest, phonotrauma or trauma to the larynx. Something more permanent might be a total glossectomy or removal of the tongue and laryngectomy, a severe or chronic dysarthria, severe or chronic and chronic global aphasia. And that use would be language as opposed to, well, language and it may be speech. Okay. Who uses AAC? You see here, this is by no means comprehensive. These are just most common developmental disorders, people on the ASD spectrum, people with cerebral palsy, Down syndrome, Rett syndrome, severe childhood apraxia of speech or speech sound disorder, individuals with intellectual disability, and in the acquired disorders, again, this isn't an exhaustive list, but people who have a brain tumor, so head and neck cancer, CVA or stroke, PPA is primary progressive aphasia. People who've had a spinal cord injury or SCI, they may have speaking preserved, but they may not be able to write, in which case they need access to output for their writing. People who've had a TBI can have dysarthria, they can have cognitive issues and motor speech issues, as well as language issues. People with degenerative diseases such as ALS, MS, Huntington's disease, or Parkinson's disease, and also people with cognitive impairment, so Alzheimer's and other dementias. For example, I have a client now I'm working with who has frontotemporal dementia. He's not using AAC yet, but we're working on cognition, and he's heading towards setting up some AAC. We work across the lifespan to support both speech and language in development as well as dissolution. And importantly, literacy skills are not necessary to use a variety of AAC options. However, literacy skills are critically important to teach people who use AAC. And we can also use AAC to support cognitively based deficits. Okay, so we talked about alternate access. Physical access is how a person accesses their AAC system in order to use it. So I did mention direct selection, and we look at that usually first if that's an option. Usually the person makes a selection or a choice on the system via touch. So that's what you're doing, or looking or speaking. I know that sounds crazy because you're thinking this is AAC. If they were speaking, they don't need it, but let me get to it. So touch could be via finger, head stick, hand, a stylus, whatever it is, comes in direct contact with the AAC screen or the system. So if you think about using your keyboard, you're directly touching the keys. You could also point via finger, hand, a stylus. The medium might not come in exact contact with the screen, but is directed towards a target. Eye gaze or eye tracking is looking at a target. So the person using the system makes selections via looking at the targets. Eye gaze systems are really cool, amazing technology, but require very careful calibration and something you have to familiarize yourself with before you would ever try and use with a client. But you would consider eye gaze for someone who has no other option for access. And we often use it like with people who have, for example, ALS, if they have lost or are losing other physical functions. The ocular muscles are, for the most part, well preserved for people with ALS, so they can use their eyes very well. And we're able to harness that with great technology these days as a method of access. And then speaking, so using speech recognition software, so the person using the system could dictate what they want to type. So I'm thinking of the spinal cord injury here, somebody for whom speech is relatively spared and they can calibrate the system. So they're not touching a keyboard, but they're dictating exactly what they want. And Google, for example, is working on better speech recognition for people with dysarthria and various other speech intelligibility issues so that they could be more readily used as a method of access. So I mentioned alternate access when the user can't use direct selection. So we have to find another way for the user to interact with that system to make a selection. So one of the most common methods of indirect selection or indirect access, usually it's called indirect selection, is called scanning. And it is what you would imagine scanning is. Choices are presented to the person who uses the system, and they indicate via some predetermined signal when the desired target is reached. So if you think about it, here's an example for you. If you go into a restaurant and you're looking at the menu, you may, when the attendant or server comes over, you may point at what you want. I'd like number two, or I'd like, whatever it is. Uh, or you might just say it. You could point to it. That would be direct selection. But if you were sitting on your hands and you weren't able to use your speech, you would have to find another way to communicate what you want. And maybe the server would say, okay, do you want number one, number two, number three, number four? And maybe you would let's say, give a thumbs up if you could, or shake your head for yes, or blink your eyes for yes when they get to the one you want. But somebody else presented the options to you. So that's what scanning is. Um, Scanning involves a selection set, which is, think of it as the whole menu. All the options, the symbols, the messages, codes, whatever, that you can choose from. And the selection set, of course, is influenced by level of literacy, the person's vision and any visual defects or field constraints they might have, and then the person's comprehension. So if you're working with somebody who, for example, is highly literate, you could go through the items of the menu. If they're not literate, you could still scan, but you could have a picture menu and pick the food they could pick the food they want based on that. And ways that we accomplish scanning are using switches. They're hardware that open or close an electronic circuit. And there are a zillion switches on the market that meet a variety of needs. So some people have the ability to, for example, use a very light movement. So I had a client who, for example, their hand was on the wheelchair support, and they only had very, very slight movement of their pinky. Very slight. This is much more than they had, and didn't have a lot of strength in their pinky. This was someone with ALS. And so they could only use a switch that required the lightest, like a feather touch, basically, versus other people who have, let's say, can use their elbow, but not their fingers, and they can rest on something, but then they have trouble lifting their hand off or their elbow off. So they can create a lot of pressure, but may not be able to release it. And there are other switches that people use. It's called a pneumatic switch, or using intraoral pressure. So you can see that there are a multitude of options, and that's why it's part of our purview to know all about this, but also helpful to work with OTs and PTs who are knowledgeable about this in discovering what's going to be the best option for your client. Some people use more than one switch, so you could use, excuse me, two-step scanning, where one switch is used to sort of start or navigate, and the other is used to make a selection. Again, two-step scanning is not uncommon, but definitely needs a higher level of training. So quickly, again, they're not going to ask you this, I doubt, but important to know. Mechanical switches are the ones that you activate by just basically touching it. So in the last picture, the last slide, these pink switches and red one on the far right are mechanical switches. So you just press on them. An electrical switch, no pressure required. Some travel is a fancy way of saying how much distance you have to press down, but these don't provide as much feedback. Pneumatic, that's a sip and puff switch. So use inhalation and exhalation for activation of the switch. And usually it's sort of on a headset or on a chin mount. And again, often used by people with um, spinal cord injury who are able to create intraoral pressure, but maybe can't use their hands at all. Um, Electronic switches, switches that work via activation of infrared or sound or some kind of sensor. Uh, and then we have brain-computer interfaces, which are um, really have been in the news fairly recently. Elon Musk launched a trial of the Neuralink, um, and another company also launched one, which I'm sorry, I don't recall the name of right this second. But they don't require any activation physically on the body. What they do in various ways and to various extents is capture changes in the brain's electrical activity as the intended activation. So invasive BCIs, and you might see this certainly within your careers, the electrodes are placed in a very small array and they're directly placed in cortex. So this requires surgery. SLPs are likely not going to be doing certainly the surgery, but you could certainly be involved in the placement of it and in training individuals. On the other hand, non-invasive BCIs, the recording sites are at the scalp. So it's not invasive in your cortex. And the recording sites are at the scalp or via magnetic brain forces. The thing here is you have to find the signal to noise ratio and attenuate the noise in the system. So this is where a lot of engineering comes in, a lot of fine tuning. Um, and for people who lose the ability to use even the most sensitive switches, even eye gaze, something like a BCI could be a lifesaver. But right now, there's still, the research has been going on for a long time, but I would say they're not ready for prime time commercially just yet. So just to give you a visual, this one in the left side here, that would be like an EEG type of cap, and you see all the wires leading down here. So the ones that are internal, of course, require invasive surgery and then closing up the scalp. Okay, we've talked about switches. We need to do a switch site assessment. So where is the switch going to go on the person's body? Again, usually SLPs, our purview is sort of around here. In AAC, we often work as part of a team with occupational and or physical therapy who are knowledgeable about assistive technology. And what we're looking for is whether the patient has a consistent and non-fatiguing movement that can be used to activate some kind of switch. We also look at movement patterns, which really we don't learn about in school. So that's where I rely on my OT and PT colleagues, because we don't want a movement that's going to create difficulty for the person that's very difficult to perform or has the potential to create muscular or postural problems. So an ideal switch site uses a small, isolated, volitional controlled movement with sustained pressure. So usually you're able to hold the pressure and controlled release. Switch site hierarchy. This is from an OT colleague, and she said we look first like at hands, then look at the head, then look at the mouth for like a pneumatic switch, then your feet, lower extremities might be calf or knee, and then upper extremities, maybe an elbow, forearm, and then head. And there are a variety of rubrics for the assessment of a switch site available. And even if I kind of go through it myself, I will often contact an OT and PT to review that, because again, not totally our area of expertise. Okay, so let us come back now to communicative competence. Sorry, this slide should have been a little earlier, but anyway, doesn't matter. This is the acronym for this is LOSS. And this is the model that Janice Light and then Janice Light and Dave McNaughton proposed. The elements, basically, or the aspects of what it takes for a person who uses AAC to be communicatively competent. And there are four main elements here: linguistic competence, operational competence, social competence, and strategic competence. So linguistic competence involves knowing the language of the system and the language of the community. So if you're thinking about language development, we're often teaching language to a client, and that may be represented with pictures, with icons, etc. But they may have a language that maybe they use a different language at home, maybe they don't, but they have to understand spoken language and then also the language of the system. Operational competence is the technical skills needed to use the AAC system efficiently. So it could be everything from turning it on and off to adjusting the volume to maybe adding segments if that's within their purview, someone who can charge the system. Usually we designate who's going to do that. Social competence gets at learning a lot of sort of pragmatics, and often we have to directly teach these to people who use AAC, introducing themselves, saying, I use this device to help me communicate, please be patient, or please wait, I'm creating a message, or something like that. And then lastly, strategic competence, and this is sort of one of the higher levels of teaching a person who uses AAC strategies, compensatory strategies to circumvent the functional limitations introduced by use of an AAC system. So that could be, for example, communication repair strategies, or it could be something like, it takes me a while to compose the message, hold that thought, I'm getting my message ready, or could be using humor to tell a joke while, to get people's attention, and then continuing on with a relevant message. So resolving communication breakdowns, as I mentioned, letting people know when they've misunderstood the message, etc. So the acronym here is LOSS: linguistic, operational, social, and strategic competencies, all go into making a communicatively competent AAC user, and can also inform both assessment and intervention. Communication vulnerability. This is a characteristic basically of often people who use AAC. Somebody who has difficulty expressing themselves because of a disorder, or understanding information in a particular environment or situations. And people who use AAC may be particularly vulnerable in like a hospital environment, or some kind of natural disaster environment, etc. So communication vulnerability can be influenced by environmental factors. Poor lighting, they might not be able to see their system. Acoustics, if there's loud music going on, may not be able to hear their system, etc. Social factors could be lack of interpreters, lack of information about the client's language or their dialect, lack of time or training to engage with a person who uses AAC, and people are seriously communicatively vulnerable in medical environments, like in the ER, the ICU, the trauma, etc. So, just something to be aware of. Okay, so AAC fundamentals. So we talked about supports, scanning. We talked about scanning as a method of indirect selection or indirect access. And often you could use various types. We talked about using a switch. If the person, though, can hear but not see, you may have to present choices auditorily. And if they are unable to begin a scan themselves, you could use something like partner assisted scanning, where you're using low-tech display and you might say to somebody, okay, is this the letter you want? Let's say they're literate, A through D, and they would let you know yes or no. If it's no, you go to the next row. Is the letter you want E through H? And if they indicate yes, then you go item by item to get to the desired option. We're also going to talk about unaided versus aided communication. Unaided is on the body's axis, okay? So think facial expression, gesture, sign, even a big movement, for example, could be unaided, versus aided use of a tool. So unaided on the body's axis, aided use of a tool. Physical characteristics of the aided AAC, size of the device or the display, the number of symbols that are on it, if they're colored, if it's just letters, et cetera. Progressive diseases would require a sequence of AAC supports from least to most across the course of a disease. And we would also consider voice and message banking. Again, these things are becoming technologically much more common, much more readily accessed, and hopefully become really part and parcel of an SLP's treatment program for somebody with a progressive disease. Organization, layouts, where vocabulary is going to go for a person. A lot of devices these days come with pre-programmed sheets or pre-programmed sets, so to speak, or pages, which are great as a starting point, but you always want to customize what you can. Thinking about how we're going to organize vocabulary. There's a movement afoot called core vocabulary, which we'll talk about briefly, and then fringe, and the need to have actually both. R is for representation. Are you using text? Are you using symbols, icons, etc.? All of this needs to be assessed. Teamwork for assessment and therapy. And I can't speak enough about that. And then visual and cognitive support. So using visual schedules, first then or if then board, visual reference like actual objects or a picture of an object, memory book for people, labels, directions, etc. So I'm going to talk very briefly about common scanning patterns. The most important thing you need to know is that row column scanning is the most widely used scanning pattern. And what happens in this is the scan starts at the top usually and goes row by row by row until the user, let's say, makes a selection with the switch. And then the scan will go column by column by column until the desired item is reached. So there are other scanning patterns, but row column is by far the most common. Excuse me. You could also find, for example, top and bottom, where you're scanning a group of items, the top, the bottom, and then you select, is it in the top? And then usually it goes into row column. Or you could have circular scan. If you've ever looked at a kid's like Fisher Price clock type of thing, clock like a toy clock that looks like an analog clock, that would be circular scanning, or even an online spinner. And, this is like Wheel of Fortune kind of thing. That would be circular type of scanning. It's not used that frequently, but can be helpful when introducing scanning to individuals. As I mentioned, auditory scanning, when visual interaction with the device is not possible due to visual problems, or maybe they don't have their glasses with them, or they have a field cut after a stroke, whatever. Choices are presented auditorily, either out loud or privately via an earbud. And then the user selects the message to be spoken, usually via switch activation, and the message is spoken publicly. So often what the user hears is just an auditory cue, like pizza, and the message to be spoken publicly would be, I prefer pepperoni pizza. So that's what's spoken publicly, and the private message is just an auditory cue. Partner-assisted scanning, also called partner-dependent scanning. This is when the person who uses AAC can't scan independently in any way. As I mentioned, it usually goes row by row. The important thing here is the communication dyad or communication partner has to have a predetermined signal that the user can do, something like a slight head nod, an eye blink, or something even sticking out a tongue if they can do that, for yes. And they don't even need a clear no or a sign for no. And then as you go through it, they indicate when you've hit the desired target. But both people who are going to use that need training. So it can be very efficient, but has to be, both users need to be trained to use it. We talked about unaided versus aided communication. Unaided, the body's access, gestures, manual sign, gaze, pantomime, head movements, facial expression, and even vocalization, not verbalization, but vocalization. Versus aided refers to using external equipment. So it could be objects, pictures, line drawings, etc., on a speech generating device or an SGD, or a communication display. Okay, so here's just a visual. So unaided, signs, gestures, gaze, vocalizations, and then aided includes all these other things here. No tech versus high tech. Aided can be further subdivided. So this might come up. No tech refers to a type of AAC system that is non-electronic. So you don't have a battery, you don't plug anything in. So an example would be a use of a simple system, like a communication board or display, even a pencil and paper, white erase board. That could be considered no tech. Low and mid tech refer to simple electronic devices on which a limited number of messages could either be recorded or programmed. And usually these devices don't have rechargeable batteries. This could be like a single message type of switch or very basic type of devices, or you may have seen what's called a boogie board, and that's like an electronic message slate. So somebody can write on it, press a button, and the message disappears basically. Is it one or the other? And I think you'll find most clinicians say, if you get a high-tech AAC system, um, like a speech generating device or an eye tracking device, you definitely need a low-tech backup. Could be a paper replica of the back of the high-tech system, or it could be entirely different. And the AAC team doing the eval should work on that. And let me give you an example why you need a low-tech backup. You're not taking the eye tracking system, sorry, into the bath or shower. What if the power goes out and it hasn't been able to be charged? Like if there's been a hurricane or a tornado or something like that. Need a way to communicate that doesn't rely on batteries or power or something like that. We also need to think about emergency preparedness and the need for somebody who relies on AAC to always have a backup. There's a continuum of AAC, so you can just see no tech is a gesture or a sign. Low tech is the single message type of things, or paper and pencil type of things. Mid tech, a few more messages, but certainly by no means many. And a higher tech device that can be programmed. This looks like it can pick up eye gaze maybe, and a lot of different options. Low and mid tech options can overlap. My sort of guiding principle, if you will, is start small and build big. So S2, S squared, B squared. Mostly because each person's trajectory is different. So we can also customize in terms of adjusting various features to best fit the person who uses AAC, big long acronym there. And we can also personalize a device to reflect the person's personality, like what color case do they want? Do they want specific vocabulary? Are there decorations, just like you might have on your laptop? Again, another visual of low tech versus way at the end high tech eye tracking systems. Just to know, AAC is part of the larger assistive technology world. And many people who use AAC may also use other assistive technology, like a wheelchair. They might use a writing aid. They might use assistive technology to accomplish ADLs, or activities of daily living, like an adjusted toilet seat, a grabber, a zipper pull, etc., as well as different transit. So they may not use public transit, they may use what's called paratransit, which is usually a parallel transit system. Okay, looking at the time, well, let's see here. We're moving, but not that quickly. Okay, types of representation. You can have symbol-based systems. You can have photograph-based systems, using either stock photos or album photos from their album. Text-based, meaning orthography. So the person would have to be totally literate, or any combination of all of these. Part of our assessment will determine what is best for that individual. Something to know about symbols, thinking about the transparency of a symbol. Transparency icon or symbol has a very close relationship to its referent, versus something opaque like the orthography really has no direct relationship to its referent. If you know English, it's, the word dog, but that combination is relatively arbitrary. And then in the middle, you have translucent, a symbol that sort of resembles the referent, but is not exactly in a tight relationship with the referent. Visual supports, I think most of you probably know this about visual schedules, using pictures or symbols. You can use the daily schedule, or you can use a schedule within an event like washing your hands, brushing your teeth, getting dressed, etc. Visual scene displays can be used where there's a contextually and personally meaningful picture, usually containing some action. There can be messages programmed in hotspots in the visual scene. We could use white erase boards and an electronic magic slate, sort of like the boogie board. These tend to be thinner and lighter than the white erase boards. Some people prefer them, some people don't. And then cognitive supports would be external memory aids, something like a calendar, or even a white erase board, memory book, notebook, post-it notes, etc. These are all low-tech aids for people with dementias, progressive language disorders, etc. Could be a cue for an appointment, task completion, social engagement, whatever. And also helpful for scaffolding, reminiscing, and conversation about a pictured event. A memory book or a life history book, sort of along the ideas of a scrapbook, but often created for people with dementia or other cognitive impairments, looking at, family members, where I went to school, if I served in the military, got married, or whatever the type of work I did, et cetera, et cetera. Could be electronic, so you could use an app to do this. I've done with Pictello or any of the other apps. Usually we have some text, because reading is pretty well preserved for people with dementia. And the technological ones, like Pictello, have auditory readout, which is actually really very nice. Or you could use a talking photo frame, etc. Physical characteristics of aided AAC. So that's external to the body's access. How many symbols, whether they're colored, is there space between the symbols, how big are the symbols, so the size, the dimensions of the display or the device. Think iPad mini versus a large iPad, etc. These are all things to be assessed. And mostly these days we have dynamic devices where the screen changes following your input. So think about like an ATM or like the screen of your phone. Once you touch something, another screen comes up. We can have, I'm going to go into the picture of this actually so that you can see. Okay, organization of grid displays, so you could have topic boards. These are designated for a specific topic, hence the name. So this one could be an Easter egg hunt. This could be going out for lunch or fast food, something like that. Hot dog and mustard, etc., or a drink. You could have one for bath time, another topic board, something with pain. And here you have a bigger symbol, obviously, in the middle, and relevant other symbols that maybe are less commonly used around there. Again, dedicated for hospital use, versus here you have more of a excuse me, grid display where you have parts of speech. So you have In yellow, you have pronouns. In green, you have mostly verbs. In blue, you have prepositions and adjectives. In red, or sometimes it's considered orange, these are other words, and you can compose a sentence using the grid. Often from left to right, this color coding scheme is often referred to as the Fitzgerald key system, originally developed for people with hearing impairments, but definitely used in AAC systems. You'll often see this repeated. Visual scene displays. So if you look here, this is a picture of two kids playing with a beach ball. There's a lot of action going on here. There's a good context. It's not just kind of some flat icon, basically. And you could program hotspots that have different messages, like my turn, you kick the ball, you know, do you want to go get a drink? Let's run and hide, whatever. Could be used for adults and kids. And this says VSD for children, but you could just as easily have a picture for an adult. This is called the navigation bar. This is the main visual scene display. Because they attract attention, they capture both spatial and temporal aspects of an activity. So this is how the person would pick another VSD. So there are sort of thumbnails of other scenes, and then within each scene, the messages can be embedded. You can also have just videos, use of video VSDs these days too. You can also have an alphabet display. This one here, whoops, sorry. You'll notice the vowels are down the leftmost side. This is fairly common for use with a partner-assisted scan. An alphabet board could look just like your QWERTY layout or your keyboard layout. You can have any other layout too. Whoops, sorry, keep doing that. Where the vowels are highlighted in a different color. You could have frequency of use layout with letters that are most frequently used arranged along like the top line, and that would vary, of course, according to language. Important to know for AAC systems, there has been for many years a movement afoot called core vocabulary, and this is a small set of vocabulary items ranging from 4 to 36 as a starter and up to like 80 roughly, comprised mostly of verbs, adjectives, adverbs, and some pronouns. What you'll notice is missing is nouns. The research on this suggests these cover 80 to 85% of communication needs. So core would cover roughly what you need to say. Then in a day, let's say, then everybody has some fringe vocabulary. And fringe is like what you think, the extra, the sort of adornment. And this is situation or topic specific vocab that is used less frequently than core. So my example of this is photosynthesis. Not a word that comes up that often, certainly not used every day unless you're teaching about photosynthesis. And fringe is mostly nouns, but not always. Whereas core is mostly verbs, adjective, adverbs. Think like make, do, go, fast, something like that. Some recent research, though, suggests you can't just rely on core for language development, that we often use core and fringe. I'm not saying photosynthesis, but that we often need specialized vocabulary for a given environment at home. And so strict reliance on core may not be the only way to go. So we've come back to AAC supports for SLPs. Speech generating devices can be either dedicated or non-dedicated. Non-dedicated are anything that's commercially available, like tablets. Once tablets hit the market, the sort of manufacturers had to quickly retool for dedicated devices. And those are devices whose sole purpose in life is for communication. They don't support entertainment. They don't support anything else. And then language and literacy. These are keys for any client. Either we're working on language development, restitution, compensation for loss, and literacy is a key to everything in the information age. There are programs dedicated to teaching AAC users literacy skills because they don't have the same ability or agility usually to practice like phonological combinations and phonological awareness and some of the other sound practice that typically developing kids have. Pulling it all together in issues in AC, funding and insurance, the bane of every SLP's existence when you have to apply for funding, access to services, getting ongoing support, people having enough pre-service training, and the influence of AI on AAC, which is huge. Much of it is for the good. Some of it may not be as good. And BCI. So as I mentioned, when we talked about it, definitely becoming much more in the limelight. And I think we'll soon be ready for prime time, probably within the next 5 years. So as I said, dedicated devices, speech generating devices, these are often made by AAC manufacturers versus the non-dedicated, which are commercially available. So a mobile tablet, laptop, computer. What manufacturers have done is made a non-dedicated device like a tablet into a dedicated device with certain machinations, and you can get into that with the literacy, as I mentioned, so critical for people with complex communication needs. You have to teach with special attention to teaching phonological skills and ways to practice these skills that don't rely on speech. So there are full programs developed for that. And quickly, as we run through assessment, I will say, find out why the person wants an assessment. And then you have to go through an awful lot to do a full comprehensive evaluation. You should know, though, there are no standardized tests for people who use AAC because of the heterogeneity of the population. So there are tests, information, checklists, type of things available, but no standardized tests. Like you won't find the WOB or the CTOPS or something like that for people who use AAC. There are a couple, as I said, on the market. I don't think it's worth going through them because I don't think anybody's going to ask you about that. And part of our assessment is, we're just about at time, feature matching. So where you match the person's needs and skills with the AAC option, system, app, whatever. And it's a repetitive or iterative process until you can find the best fit. And you often will make a chart that looks something like this. So I'm thinking here, app A, app B, app C, app D, and some kind of checklist so that you can, at the end, look at what you've tried, see what the person likes, what meets their needs, their wants, their skill, and fits. best, because some things are free, some are not, etc. So I don't think we'll get into that. I did want to mention, because this might come up, there is no research, let me repeat, no research to suggest that use of AAC will impede speech development. And often clinicians get this as a question. And in fact, the research indicates that use of AAC, both low and high tech, but often a little bit more on the high tech, can promote increased communication. And use of high-tech AAC can provide repeated exposure to that speech and language model that provides endless opportunity for imitation. So often what you have is kids or people listening to what the device says, then trying to repeat it and imitate it a zillion times, which we could never do in therapy because it's just too time consuming. But it's definitely out there in the literature. Okay, so that is the thumbnail approach overview to AAC. I know we've run over time and I appreciate your time. I can stay on for a few minutes for questions. Okay, in the chat, are selections presented verbally? Is that for partner-assisted scan?
It was for the scanning method.
For scanning.
Yes, auditory. Yes, yeah. Thank you.
For partner-assisted scan or auditory scanning, absolutely, verbally. For other scans, it could be just looking at a device, and often you'll get like a highlighted, colored highlighted bar, and it can be presented verbally, but someone who can take in the visual information doesn't necessarily have to have the verbal. Anybody else? Any other questions? Questions from the book? Anybody not sure about an answer? You guys are rocking it. I wish you every bit of good luck. Please feel free to reach out if you have questions. I think you can reach out to Therapy Ed and they would certainly direct you my way.
Yes, I will second that. We're more than happy to do that. And just wanted to say thank you so much to Dr. Gutman for coming out and giving us that presentation.
My pleasure.
And if there are no other questions, we'll say goodnight for now, but hope you guys come back next week for another discussion.
Take care, everybody. Thank you.